that I have set this up. So
Can hear me, Doctor.
excellent. Thank you. Okay, here we go. All right. I want to make sure I can pull up the messages so we can go ahead and get started. As I mentioned earlier, we were going to start talking about the topic of menstruation. What fun. Things that that are important for you to know, especially, well, not especially, but essentially, if you're working with women of reproductive age. And we'll start by defining some important terms. As we did in the morning, there will be some embedded questions in the lecture, just both as reminders of topics or material that we have just covered, and as a way to help you prepare for similar questions in the exam and facilitate your learning. And of course, if you have questions during the afternoon session, questions for me, feel free to unmute your microphone and speak out. There will be some times when I ask questions of the group, and we'll rely on the chat at that point for you guys to enter your answers. I do want to say during this part of the chat or the class, there will be several case studies that we're going to go over, and I will give you time. I'll give you some information and some time to think about the case studies, and we'll have some discussion opportunities, I hope, to be able to, process the information from those cases. Okay.
I have a quick question.
Sure.
I'm wondering, as a prescribing psychologist in the Air Force, how much of your time is spent basically managing medications versus like psychotherapy?
Oh, thank you for the question. I'm going to say, just like every other psychologist answer every other question, it depends. I will say probably 50 to 60% of my caseload is comprised of people who are who are seeing me both for psychotherapy and pharmacotherapy. About 20% of my cases are pharmacotherapy only, meaning they were referred by another psychotherapist, either a social worker or psychologist, and are receiving psychotherapy or will continue to receive psychotherapy from those providers while I prescribe. And then maybe 20% are cases that are referred to me for psychotherapy from psychiatry, or who came in through the clinic referral system and are not being prescribed. But that depends a lot on the needs of the, primarily on the needs of the patient, but also on the needs of the clinic. Right now I'm in a situation where I have the luxury of being able to do both of those pretty equally, or as the patient needs present themselves. In other situations, especially in other assignments where we had we were pretty low in prescribers, but maybe had more psychotherapists, and I would do more medication management. And then sometimes, at least once in my career, we were pretty high in the number of prescribers in the clinic, and I did mostly psychotherapy. So it really depends on the needs of the clinic and the needs of the patient. Does that answer your question?
Yes, it does. Thank you.
Yeah, no problem. All right, so we'll start defining some terms related to menstruation. Some important ones that you should know about are menarche, which is the onset of menstruation, so the age at which most girls or girls start to have their periods. Usually menstrual periods begin between the ages of 11 and 14 in the United States. The best predictor is a mother's age at onset, and lately we've seen onset of menstruation in girls as early as 7 or 8, which is quite impactful, I have to say, and requires a lot of preparation and education that perhaps girls in elementary school are not getting. Menopause is a discontinuation or the end, of menstrual cycles per se, a term that most people should be pretty familiar with. Women usually start to have fewer periods between the ages of 39 to 51. And once again, the best predictor of the ultimate discontinuation of menstruation is the mother's age at menopause. Amenorrhea relates to the absence or delay in menstruation, and there's primary and secondary, which we're going to talk about. And dysmenorrhea, as the name implies, refers to irregularities in menstruation. And some of those are normal irregularities, such as after menarche, girls, it takes several cycles for the girls to have a predictable pattern of menstruation. Some of those irregularities associated with dysmenorrhea or secondary dysmenorrhea may be less normal in that they may be the result of diseases, metabolic and hormonal type of agents or problems, and things like eating disorders. Okay, here's another picture. Again, not anything that you should memorize, but it's helpful to understand how menstruation happens. So, in order to have successful menstruation, I guess one way to talk about it. The hypothalamus has to release GnRH, or sorry, I'm having trouble. Essentially, the activation of the anterior pituitary gland that allows the factors that promote the release of LH and FSH from the anterior pituitary gland. So if you recall, we talked about the follicle stimulating hormone and the luteinizing hormone as being significant factors in the prediction or the function of the menstrual cycle. Again, if you look at the top of the screen here, the mid-cycle peak in LH, or luteinizing hormone, triggers ovulation, and those decreasing levels of LH are seen in the later part of the menstrual cycle. What's going on? So in the top of this graph, what you see is what's happening from a hormonal level, and in the bottom or the mid section, you're seeing what is happening in both in the ovaries and as a result of this peak levels. So day one, or the beginning part of the cycle, I should say, we have the follicle stimulating hormone promoting essentially the growth of the follicle. That's why it's called that, which is essentially going to be released as an ovum during ovulation. After its release, if it is not conceived, if it does not interact with a sperm, thank you. Gonadotropic releasing hormone. Thank you, Dr. Gupta. Having some moments here. If it's not, if there's no conception going on after ovulation, then we refer to it as the corpus luteum, which ultimately disintegrates, at the end of the cycle. And you see estrogen levels peaking once again around the mid-cycle, followed by past the midpoint of the cycle, a peak in the levels of progesterone, which ultimately, if you look at the course of menstruation from 0 to 28 days, results in the thickening of the endometrium. This is what you see up here, the endometrium being the surface of the uterine, endometrium being the surface, a blood-rich surface of the uterus that sheds off if there's no conception. So ultimately it's not so important that you know all these things, with great detail. The important thing to take away from this is the impact of the hormones in all the different parts of the menstrual cycle, as well as what that means in terms of how menstruation may manifest. Um, let's see if there's anything else I want to. Nope, I think that should cover it. Here's another picture representation, and again, it's essentially showing somewhat the same thing in different, in different separated by different things. So if you look at the second box in this graph, you see that body temperature tends to remain stable in the first 2 weeks of the cycle, with a sharp increase around the middle of the cycle, which is once again what I mentioned before, aids in the prediction of ovulation and helps women and couples that are interested in using natural rhythm for contraception or conception, who are interested in getting pregnant, may use basal body temperatures as a predictor of ovulation. You see what happens with the anterior pituitary hormones, the LH and the FSH, in the middle of the cycle. In the next box, you see what happens with the ovarian hormones, those that are produced by the ovaries, estrogen and progesterone, and ultimately you see about the thickening and later deterioration of the uterine wall that causes menses to occur. And then the cycle repeats. Okay. Some things that are, I think, important for you to know about the effects both of those hormones and how they represent in the function of in functioning for women. As a result. So one study, and actually I did review, I did a literature review and found that there's actually a meta-analysis of several studies that show that women have present with higher mood and verbal functioning around the middle of the cycle, highest sex drive also around the middle of the cycle, as you can see here. Highest and peaks in visual spatial abilities about 3/4 of the way into the cycle. So probably the peak in visual spatial abilities is going to happen about 3 weeks into the cycle, with a sharp decline, as you could see right after that. And so, you could see from an evolutionary perspective why it might be useful for mood and verbal skills and sex drive to be elevated during the peak parts of the cycle. Peak meaning, the times when ovulation can occur. The visual spatial skills and functioning, that's a little bit harder to understand perhaps, and maybe you guys have some ideas as to what that might be. But I do want to point out that this sharp decline does present functional limitations for some women, and you will find women who report being clumsy, more prone to accidents, really being having difficulty with other visual spatial tasks right about a week or potentially a little bit more before menstruation. So part of the premenstrual syndrome or premenstrual symptoms that some women report may be associated with that sharp decline in visual spatial functioning. In addition to that, we see resting systolic blood pressure that tends to be, higher in the ovulatory phase. So perhaps for some women that also may be a helpful predictor of ovulation. And diastolic blood pressure doesn't really change all that much during the different phases of ovulation. So this is just an interesting finding. It doesn't really translate into, at least from what I could tell, anything that significantly relates to function, but it may be yet another way that women who are interested in either preventing conception or potentially conceiving can use as a marker. resting heart rate was interestingly higher in both the ovulatory phase, so right in the middle of the cycle, as you can see here, and the luteal phase, which is essentially after ovulation and right before the onset of menstruation. All right. So with that, we're going to go on to talk about menstrual disorders. And some of you may be familiar with some terms in this area already. Sorry. Things like I've already mentioned amenorrhea, which is the failure to start menstruation during puberty or cessation of menstruation anytime after onset. So previously defined amenorrhea as the absence or delay. So the failure to start menstruation during puberty would be considered a delay in menstruation. And the cessation of menstruation anytime after the onset would be considered secondary amenorrhea in this case. Normal causes, of course, of amenorrhea are pregnancy, lactation, and menopause. It is thought, it is pretty common, most common for women to stop menstruating during pregnancy for sure, and sometimes bleeding during pregnancy can be a marker of a pregnancy that has gone wrong or a potential miscarriage. So that is significant. Lactation, not so much anymore. And we'll talk about lactation rates in future slides probably tomorrow, but I do want to emphasize that there's a significantly lower number of women who breastfeed exclusively after a certain period, and so lactation and lack of menstruation or amenorrhea are not as closely associated as they used to be. And most women start menstruating 2 or 3 months into their postpartum period. And of course, menopause is a complete cessation of menses, and that would be, a normal cause of amenorrhea. As far as dysmenorrhea, it's all further defined as having menstrual cramps or pain or irregularities that are beyond what we would call the normal range. So, most women will experience some pain and cramping associated with menstruation, but those that go beyond the normal range and present with significant amount of this disturbance or disruption in quality of life would be termed dysmenorrhea. Primary dysmenorrhea, just like amenorrhea, there's primary and secondary. Primary is not caused by an underlying medical condition. Generally begins when the girl starts having her period. And again, I mentioned before, it takes several cycles before a girl will phase into a routine pattern of menstruation, whether it's 4 weeks, 5 weeks, 6 weeks. It depends it varies woman to woman, but it takes, for the most part, several cycles before it becomes quote unquote routine. Secondary dysmenorrhea, on the other hand, typically occurs later in life and is the result of a problem with the woman's reproductive system. So we see it as part of, again, eating disorders. We see it as a secondary reaction to other hormonal problems or treatments, which we'll talk about. And we also see it with things like PCOS or polycystic ovarian syndrome, which may be apparent in women, younger women, following weight gain or difficulty getting pregnant. Let's see. Okay. Let's see, I want to make sure I'm in the right place. Okay. So with regards to other terms associated with the menstrual cycle and menstrual disorders, menorrhagia refers to the excessive or dysfunctional levels of uterine bleeding that occur as a normal part of a woman's menstrual cycle. So this is really not not a uncommon type of disorder, quote unquote. Again, bleeding and pain are, of course, normal parts of the menstrual cycle. And in the context of a normal menstrual cycle, what menorrhagia refers to is excessive and dysfunctional uterine bleeding, further defined in volume, and may, blood flow may be very high in volume and may last longer than the normal period. So normal period usually ranging from 5 to 6 days. In menorrhagia, you might see periods that last up to 10 days. And then there's a condition which we wouldn't necessarily call a condition because it's a non-pathological premenstrual discomfort, and that is called premenstrual melimina. Melimina is the most common premenstrual disorder, and that is, again, not necessarily pathological, not pathological, and not necessarily uncommon. Premenstrual discomfort can present with many symptoms, including bloating and, as I mentioned before, water retention and difficulties with visual spatial abilities, as well as, mild symptoms of mood, mild mood changes or sleep changes, appetite changes, and not necessarily be pathological. Premenstrual syndrome, on the other hand, is a disorder characterized by emotional and physical symptoms that occur in the latter half of the menstrual cycle, what we define as the luteal phase, following ovulation. And for the presentation, for most women, the presentation includes physical symptoms such as backache, bloating, irritability, and headache, and even GI distress and discomfort, which you can understand because, as I mentioned before, the hormonal levels, especially progesterone, that is present in the second phase of in the latter phase of the menstrual cycle, can affect motility, GI motility, and so women can present with symptoms of potentially constipation during this time. And it's typically most intense during the 7 days prior to the start of menses, and that is what we have described as the luteal phase. Not necessarily exactly 7 days, but but on average is what you might see. PMS is thought to be present in half of all women at different times in their lives, and the severity and the the duration of the symptoms may differ across the lifespan. So the same woman may experience PMS symptoms at during some parts of their life, and then not. That's important to consider. 47-48% of women is what has been defined as the normal range, with anywhere from, depending on the sample that you look at, 32% to 63% reporting some symptoms. Interestingly, as a cross-cultural finding, I want to highlight that in France, the reported prevalence is about 12%. In Iran, the reported prevalence is 98%. And you can probably intuit some interesting cultural factors that may be associated with that. Okay. Premenstrual dysphoric disorder is something entirely, not entirely different, but certainly of an entirely different severity. So PMDD is a more severe form of PMS. that also includes a psychological component. And as you know, is part of the DSM-5, therefore, diagnosis that you can make and that you can treat. Certain symptomatic criteria must be met, including interference of the symptoms with daily living. And just as a review, I'm sure you've seen this in other settings or you have used in your clinical practice. I want to make sure to highlight the criteria for PMDD according to the DSM-5. Five symptoms must be present during the most menstrual cycles in the past year. So in order to render a diagnosis, you really have to have observed or have evidence, not observed personally, but tracked or had your patient maintain logs or tracking of most of their menstrual cycles over the past year. And at least one of them must be the first four symptoms: depressed mood, feelings of hopelessness or self-deprecating thoughts, anxiety, tension, feelings of being keyed up or on edge, marked affective lability, including feeling suddenly sad or tearful or experiencing increased sensitivity to rejection, and persistent and marked anger or irritability or increased interpersonal conflict. So one of the five symptoms must be one of the four that I just listed. Additional symptoms you see in front of you are pretty consistent with other symptoms of depression: decreased interest or anhedonia, subjective sense of difficulty concentrating or lack of focus. Going on to the next slide, you could see lethargy or fatigue or inertia being a symptoms, changes in appetite, including overeating or specific food cravings. This is a little bit different from depression. We don't normally see the criteria of specific food cravings associated with depression, but more so either change in appetite to where it's to be in a higher or lower than normal. We see both hypersomnia or insomnia with PMDD, a subjective sense of being overwhelmed or out of control that is also different from the criteria or diagnostic criteria for depression or other types of depression. And in again, in contrast to other depressive or major depressive disorder criteria, you also see highlights of other physical symptoms, such as the ones that you see listed in front of you. And a keynote here on this slide is that, once again, to be considered PMDD, the symptoms must occur during the week before menstruation and remit a few days after the onset of menses. That is, be absent after menses. So what the normal pattern is, the symptoms start about a week before the woman starts menstruating. And although they may be present for several days during menstruation, the symptoms must have completely relapsed by the time the period ends. As far as the prevalence of dysphoric, premenstrual dysphoric symptoms, not disorder, but symptoms, and specifically in this slide, we're talking about mood symptoms. In samples ranging from age 17 to 64, any symptoms may be present in up to 98% of the population. I told you already about some significant cross-cultural findings. Severe symptoms are present in anywhere from 2 to 3% to 31% of the population, again, depending on the population that you're looking at. But numerically, 4 or more somatic or psychological symptoms, anywhere from 11 to 20% of the population. So you can see the ranges are pretty wide, and it's hard to ascertain with any kind of certainty what is what. But we do see that although, cultural and psychosocial factors appear to influence the proportion and intensity of physical versus behavioral symptoms, what we do find is that across cultures, the presence of mood symptoms, and even mood and physical symptoms, as well as a degree of illness and behavior, are pretty comparable. So once again, across cultures, the presence of the symptoms are pretty comparable, though you can see a wide range in some cultural and psychosocial factors that can affect the numbers, that are reported there. Um, so one of the things that I think is really critical to highlight is that premenstrual dysphoric disorder, so PMDD, it's not a benign disorder. It can have very significant impact in areas of functioning, such as some of the ones that we have mentioned before, but certainly in quality of life and what we call days of disability. So, in one review, the prevalence of PMDD being uh, determined to be about 5% of adolescent girls, and given, in with or hypothesizing that the same prevalence rate is present in older women, the calculation that was made is that PMDD may cause 1,400 days or 3.835 years of disability for each woman. And if you do the math, that translates, you can follow this with a 5% prevalence rate. Um, at least 3 million women, 3.7 million women meet the criteria for PMDD, costing the United States, this is limited to the USA, um, a 14 million years of disability. So pretty significant. If you look at this graph on slide number 91, what you can see is that the disability or the quality of life impact associated with PMDD is comparable to other diagnoses such as PTSD, a major depressive disorder, and even panic disorder. So look at what you're looking at here is from an assessment of quality of life, the quality of life scale. Quality of life, enjoyment, and satisfaction scale, and the comparisons are between PTSD in the first column, PMDD, luteal phase or premenstrual dysphoric disorder, major depressive disorder, and panic disorder. So once again, not a benign illness, even though it's time limited. Okay, so these are important things to know, and you will be asked some questions about this both in the test and the PEP. The reason that you will be asked those questions is because they translate into treatment considerations. With regards to the etiology of premenstrual disorders, it is thought that a dysregulation of serotonin and hypothalamus pituitary gonadal axis, which results in decreased availability of 5-HT and acute depletion of tryptophan, may be causal. So think about decreased availability of 5-HT in the luteal phase. Think about acute depletion of tryptophan, which, as you know, is a precursor in the development of serotonin. And the above, specifically is thought to be associated with craving of carbohydrates, the irritability, and other mood lability, as well as dysphoria and impulsivity that may be seen. Decreased GABA levels, and as you know, GABA is an inhibitory neurotransmitter. With decreased GABA levels, the expected response would be to see anxious distress and agitation, and another mechanism of action or mechanism of impact is decreased progesterone metabolite, listed there, allopregnanolone in luteal phase, which may be associated with anxiety and mood lability. So it's a multifaceted, multi-factor etiology. Again, the key things that are important for you to consider is the dysregulation of the serotonin axis, as well as the depletion of or decreased level of GABA, and how that might translate in terms of treatment of some of the symptoms of PMDD. Um, Another thing that needs to be discussed is the exacerbation of other disorders. So, in terms of when we talk about menstrual disorders, we have to talk about the ones that are specifically associated with menstruation, whether it's PMS or PMDD, and also with talk about the premenstrual exacerbation or cyclical exacerbation of other disorders. We could see this with psychiatric and medical conditions. So listed in front of you, you see a number of psychiatric conditions that may exacerbate in the luteal phase of the cycle. And those include major depression, persistent depressive disorder, bipolar 2, cyclothymia, generalized anxiety disorder, panic, bulimia, and PTSD. You may also see medical disorders, as I mentioned, including those that are endocrine related, such as hypothyroidism or diabetes, autoimmune or collagen vascular disorders, including things like dermatomyositis, psoriatic arthritis, rheumatoid arthritis are examples of collagen vascular disorders that could that could worsen during the premenstrual part of the cycle. You might see anemia be affected, of course, by levels of menstruation, and it's very important to monitor iron levels in women who, especially in women who have significant dysmenorrhea with excessive bleeding. Um, Chronic fatigue syndrome and endometriosis. And if you know anything about the mechanism or the endometriosis um, course of the disease, you know that there could be significant pain associated with the cyclical nature of the menstrual cycle that could then translate into psychological distress for sure. So there's a lot of overlap with PMS and PMDD, and this slide highlights is that PMDD and PMS are both diagnoses of exclusion. So we definitely want to rule out other conditions when we are considering the possibility of, assessing or determining that a patient needs to be treated for PMDD. Those included on the slide that you see in front of you are things like adrenal disorders, anemia, chronic fatigue syndrome, I've already mentioned, thyroid disorders, and irritable bowel syndrome. And you can see the rest of them for you. And the reason that those are listed there is because you might actually see symptoms, as I mentioned, you might see these conditions worsen as a result or in connection with the menstrual cycle, but that doesn't necessarily mean that it's PMDD. It may be an exacerbation of the disorder. Baseline lab work should include all the ones listed there, the complete blood count, thyroid stimulating hormone levels, comprehensive metabolic panel, and urine drug screen. All of those are important. Once again, want to emphasize that this are diagnosis of exclusion. I mentioned some of this already, but want to highlight that out of the a number of studies, this is a list of the most common luteal phase symptoms. So this could be symptoms that present as part of melimina or part of premenstrual syndrome or PMS or PMDD. And the majority, with the majority of responders endorsing high irritability, feeling tense or anxious, tired and lethargic. Mood swings are only present in, well, I shouldn't say only present in about 3 out of every 5 women. Sad or depressed mood, interpersonal conflicts, and again, you could see the rest of them for yourself. Poor concentration is still pretty significant. So once again, one of those symptoms that most people wouldn't necessarily report spontaneously, or may or may not cause, significant distress, but that you definitely want to assess for if you're considering the possibility of diagnosing someone with PMDD. Um, Looking at whether it's PMDD versus a premenstrual exacerbations, the key factor is whether the symptoms are present throughout the cycle, because if that's the case, then by definition, it's not PMDD. If the symptoms are only present during the luteal phase of the cycle and they cease to exist, as I mentioned before, at either the onset of menses or certainly by the end of the period, then they would be consistent with PMDD. Premenstrual exacerbation, or PME, means that you have an underlying psychiatric condition and the symptoms worsen or change during the latter part of the cycle. And this is what that graph is exemplifying. Sorry, you couldn't see all of it before. Okay, so we're going to run into a case example. This is, the first of several that we will be discussing throughout the class. So what I want to do is I'll give you some information, both demographic and clinical information about this case. And then I want you to take a few minutes, 3 to 4 minutes. So this might be a good time to get note-taking material if you don't have any, or if you want to use your computer to take some notes. What I want to use the 3 to 4 minutes after the information gathering is for you to either come up with some questions or additional information that you would want to know about this case, and then some potential formulation in terms of diagnosis and potential treatment treatment recommendations that you would make based on the information that you have, or on additional information that you might want to collect. So think about what questions would you want to ask, or what additional assessments or exams you would want to gather, and then also think about what potential treatment plans or treatment recommendations you would make. So I'll go over the demographics and the clinical information about the case a couple times just to make sure that everybody gets it. And feel free to get clarification if you miss anything. So my case is that of Sylvia. This is a pseudonym, of course. 32-year-old Latinx cisgender female who is married with 2 children from a previous spouse. This is her second marriage, and presents with significant depression with what would be considered atypical symptoms, meaning she reports hypersomnia and hyperphagia, or heightened appetite and overeating. She also reports sadness, irritability, fatigue, and difficulty functioning in general. Some psychosocial factors that are important for you to know is that her previous marriage was an abusive relationship. She left the marriage of her own accord. She's a single parent, or had been a single parent for years for her 2 children, and the children's ages I'm not are not in my notes, but I seem to recall that at the time that she was in treatment, both of them were teenagers and one might have been college age. Her second marriage is pretty recent, and also recently she was discharged from the military through military retirement. It was not it was not a negative discharge. It was a medical discharge, medical retirement, and she's currently unemployed. Okay, so once again, I'm going to go over the factual or demographic and clinical factors of the case in case you missed anything. So once again, Sylvia is a 32-year-old Latinx cisgender female, married with 2 children from a previous marriage from the previous spouse. meaning the children are stepchildren to her second husband. She reported significant depression upon her presentation, with a presentation that was somewhat atypical in that she reported hypersomnia and hyperphagia, and if I recall correctly, reported sleeping about 12 hours a day and had gained at least 20 pounds by the time she entered care. Sadness, irritability, fatigue, and difficulty functioning in everyday life. Some psychosocial factors that are important to consider is that she was in a previous abusive relationship for years. She left her first husband and had been a single parent before meeting her now second husband. And this is a relatively recent marriage. And she was also recently medically discharged from the military and is currently unemployed. So it is now, I don't know if we can start a clock, but let's take about 4 minutes for you guys to consider some questions that you would want to ask, or assessments that you would want to make, and then some potential treatment recommendations based on your differential diagnosis. So Carmen asked, what was the temporal relationship between her depressed symptoms and all her life stressors, starting with marital abuse? The depression is relatively new. She had left a marriage years back and had been a single parent for several years. I want to say at least 5 or 6. And the depression had started recently, about a year prior to my assessment of her. Question about when did she leave the military? She had been medically retired maybe 3 months before she started treatment. It was relatively recent. Joy is asking, is she reporting any binge eating or restricting behaviors? No restricting behaviors, but she does report periods of eating that, or a desire to eat, and having lost on occasion, not routinely, reporting that at least some perceived loss of control over her eating. Kirsten says, when was she diagnosed with the medical reason for discharge? This is a strong factor in depression, loss of identity. I would agree. She was discharged, ultimately discharged for a back pain, back condition, chronic low back pain. She had been experiencing symptoms associated with this pain for some time. So I want to say probably years before she was eventually discharged. And just in the interest of making sure that everybody has an opportunity to think about considerations, I'm going to continue to answer the questions after a couple of minutes. All right. Hopefully, most of you have had the opportunity to think about additional questions. Keep throwing them in the chat box. We'll go over them as in order, and I'll clarify anything that that I haven't so far. Let me make sure that I did address. I think I got as far as Joy. Sorry, Kirsten. Eddie says precipitating factors. Um, there again, recent, I would say the onset of depression was at least temporarily related to the decision to be medically separated from the military or medically boarded. Marriage was relatively new. I wouldn't say that was a precipitating factor for the depression, but there was a change in living conditions, and that she was a single parent before. Now she had her husband who was active duty, and now the primary earner. In different living conditions, moved away from her last home of record to join her husband in his current assignment, so didn't have hadn't developed a local support system. And her husband traveled frequently as part of his current job. So even though they were married, she was still, to some extent, living the life of a single parent, at least sometimes. Family history of depression, I think, was positive for mom, biological mom. Nobody else in the family had experienced any depression that she was able to report. Age of onset for depression would have been around 31 years of age. As far as changes in medication, she was not taking any psychotropic medications when I first saw her. And I think somebody asked before, did she have any depression? Was she taking any medications for pain? And as I recall, she wasn't taking any opiate medications. She had different courses of therapy before, including physical therapy, and was currently being treated, or at the time being treated, with NSAIDs, some Mobic or something along those lines. Other chronic health conditions, none were present or reported. We did have her thyroid check, and that was within the normal limits. And yes, there were thyroid labs completed, as well as CBCs and other baseline labs. Eddie asked, any physical abuse in the current relationship, and that was denied. So she did not endorse any physical or psychological abuse going on in her current relationship. Brady says, has anything changed between she and her current husband? I've already mentioned a little bit of the dynamic with him being there, but also being gone a lot, and having a blended family with at least one child in the home. I tend to think that she had a preteen or teenager who was living in the home, and a college-age kid who was not. That was an interesting dynamic. Let's see. No evidence of abuse in the current relationship, at least not by her report, and she described him as very supportive and loving. Back pain is not disabling, not anymore. At least it would preclude her from carrying her gear or wearing her armor in a way that made her disabled as far as the military is concerned, but not necessarily disabled from a civilian functioning or functional perspective. Medication prescribed for back pain, I've already addressed. Has the screen been done for abuse risk in current relationship? Yes, it was denied. History of substance abuse, she did report periods of increased drinking, some impulsivity associated with, at least as a single, during the time that she was single, one night stands, or what she herself described as promiscuity, that was related to periods of increased alcohol use. But at the time of treatment, she denied any significant symptoms of alcohol use disorder. Could she be pregnant? Possibly, but we did check and she was not. Any concerns for potential secondary gains, reporting symptoms of depression prior to getting out of applying for VA disability? And not at all. At least not in my estimation based on when I was treating her. Sleep issues, yes, very significant. As I said, her pattern tend to be, I want to stay in bed all the time. I'm not sleeping or not sleeping well. But I still want to stay in bed most of the time. So there was hypersomnia in the sense that she spent a significant amount of time sleeping, but it was non-restorative, and yeah, non-restorative. Does she still need to communicate with ex for co-parenting issues, and does this cause any significant distress? Great questions, by the way, everybody. So far, so good. She did not. He had been out of their lives for some time, and neither her nor the children were interested in having any kind of significant relationship with him. In fact, she had foregone any kind of child, or what's the word I'm looking for? Payments. He didn't make any payments for their support. Thank you, child support. She had foregone that, for the benefit of not having any kind of relationship with the father of her children. Others symptoms suggesting hypomania, mania. I've already mentioned a couple of them. Some impulsivity with regards to both eating and consumption of alcohol, as well as promiscuity, per her description. Had she been planning on being in the military for 20 plus years? How long had she served? She was 32 years old at the time, and I want to say her time in service was probably along the range of 10 to 12 years. That's fairly typical. And yes, the answer is she had planned to be in the military through her natural retirement, and that, of course, did not occur. Okay, great inputs, everyone. So what are your thoughts with regards to diagnosis? And also, what are your thoughts with regards to treatment for this individual? Let me be more specific, maybe. Do we have a premenstrual exacerbation of a primary psychiatric disorder, or do you think we have a premenstrual dysphoric disorder? And I bring it up because she did report a pattern of symptoms that was heightened during the premenstrual phase of her cycle. Based on everything that you've heard so far, biopsychosocial factors included, do you think we have a differential diagnosis of premenstrual exacerbation or a premenstrual dysphoric disorder? Or do you think something else is going on? Come on, somebody has to be first. Thank you, Eddie. I was thinking MDD, single episode moderate, escitalopram to start. Good points. Will do her symptoms go away? Not completely, no. She's been depressed for about a year. They just get worse. Eddie Taylor says depression. Kirsten says premenstrual exacerbation of either MDD or bipolar depressed. SSRI if not able to benefit from talk therapy. Okay, good thoughts. Anything else? Could we potentially conceptualize this as an adjustment disorder based on the congruence of confluence of factors? Exactly. Like Angela says, like leaving military and adjusting to civilian life, could be a factor in potentially an adjustment disorder. Um, mhm. Okay. Good points. No one's wrong. And I don't, obviously we're never wrong in the sense that we don't really have a lab marker to tell us what diagnosis is correct. But the way we conceptualize this patient, at least at the time, based on the severity of her symptoms, we determined that it was not an adjustment disorder, she met criteria for a major depressive disorder. However, someone, I think, Kirsten, and a few others were worrying. Carmen worried about the possibility of mania. And I said some things that could have cued you to the possibility of mania, including the fact that she had evidence of impulsivity, promiscuity, impulsive use of alcohol, or excessive use of alcohol during some time in her sometimes during her condition. Two other things that I want to cue you in with regards to the possibility of hypomania or a potential bipolar presentation are the presence of hypersomnia and hyperphagia. More and more evidence speaks to the idea that atypical depression is much more likely to be depression associated with bipolar disorder as opposed to really an atypical MDD. So if you hear hypersomnia, hyperphagia, in the absence of other markers of mania, I would just recommend that you keep a watchful eye. So with that in mind, let's say we go with the MDD with PME, so premenstrual exacerbation. And Carmen asked, how would they be treated differently? Well, we know from the formulation about the etiology of PMDD that serotonin or serotonergic drugs or potentially GABA drugs may be beneficial. However, we have a situation in which we suspect that there may be a bipolar or underlying bipolar condition. And so a possible switch to mania may be problematic. And so in this case specifically, my choice was to go with Wellbutrin as opposed to a serotonergic drug. This still didn't address the premenstrual exacerbation of her symptoms, but we thought if we could treat her depression and minimize the potential switch to mania, we would have the ability to observe and change course if needed over time, and with more evidence of whether it was one thing or the other. Um, the Wellbutrin tends to be less activating for mania, and in fact, if you suspect mania, maybe in the medical history, through the medical history or family history, it is much more beneficial to consider Wellbutrin as opposed to an SSRI or even an SNRI, which is why we decided to go that route. And in fact, it has a couple of additional benefits that for this patient specifically may be useful. If you recall, her presentation of depression included hypersomnia and hyperphagia, or heightened appetite, as well as fatigue and difficulty concentrating. And so all of those things could potentially be treated or could respond very well to bupropion or Wellbutrin. And so from that perspective, we thought it would be potentially an easier buy. Given all of that, given what I said, even though it has a decreased potential um, uh, to has any antidepressant could potentially cause a switch to mania. What we did is we started at a very low dose and titrated very, very slowly with very close observation to make sure that we didn't create a switch. So Angela says, I would think dopamine would increase chance of mania. DNRI, correct. And actually that's not proven to be the case. I don't, I, we don't really have, and at least as far as I know, a significant, um, I think, a conceptualization of the etiology of mania that I'm familiar with that includes the dopamine pathways, although I'm going to look that up. But I would say that in clinical practice and some of the guidebooks that you will read, um, you are more likely to see bupropion as a recommended antidepressant to deal with, some potential bipolar or mood disorders or depression associated with bipolar. Oh, I see your comments. Thank you. Um, by the way, every case is different, and and as you know, when you're looking at medication, the things, the information that you give your patients is that the exact mechanism of action of each medication is not really well known. So there's a lot to be learned yet about how this medications work. But I wanted to highlight both the premenstrual exacerbation of symptoms that is present in this case example, as well as the fact that even though we see that, we may not necessarily run to an SSRI right off the bat without considering other significant factors that may be potentially impacting the patient, including some of those psychosocial factors that we talked about, as well as the potential for a switch to mania that we had to watch out for. In the end, I treated this individual for about somewhere between 6 to 9 months. She responded very well to Wellbutrin and psychotherapy, and I'm not negating. Somebody mentioned that in the past, and for sure that was a significant part of our treatment. She did not have a switch to mania, and we were able to maintain her successfully on 300 milligrams XL of bupropion with significant improvements in her depression. And this is an example, once again, of where we could use the mechanism of action and also the side effects of the medication to help a patient. So in this case, we have somebody who's very fatigued, having trouble, sleeping a lot, and overeating, and some of the mechanisms of action of Wellbutrin were actually used to counteract those effects. Now I see it's 9 minutes after the hour, so time for a break. We've run a little bit long. Thank you all, great participation. I appreciate your inputs. So with that, let's stop and come back at 19 minutes after the hour. We'll go ahead and continue. Okay. Again, thank you for the inputs. That's how case examples or case presentations should work, and hopefully, or ideally, to enhance your learning. Okay, so we were talking about assessment of PMDD, and as I mentioned before, it's critical to remember that PMDD is a diagnosis of exclusion. You're going to have a psychiatric evaluation, potentially with objective psychological testing, especially if you suspect other diagnoses or conditions that may present with mood lability or mood swings, may be present, including bipolar disorders, mood disorders, or personality disorders. You're going to have a medical evaluation, and potentially, especially if there are menstrual irregularities, a referral to an endocrinology as needed, but at the very least, a primary care physician. Really important to evaluate family history, medication history, make a nutritional assessment, and a continuous monitoring for at least 3 months is the recommendation, although as I mentioned before, the diagnostic criteria says that you should have the symptoms present in most cycles for at least a year, and that in a woman who has an average cycle of 28 to 30 days, would be a minimum of 7 cycles. Laboratory tests are suggested, including a complete blood count or CBC, chemistry panel, or a complete metabolic panel, including glucose, calcium, and magnesium, thyroid functioning test, vitamin B12, vitamin B6 and B12, folate, and I would say I didn't add it in this case, but iron as well. Again, you know, especially if we're having dysmenorrhea or any report of excessive or irregular bleeding, you should assess for iron levels, and a mood log. Those are important things. As far as treatment, again, don't forget you're a psychologist first. So non-pharmacological treatments that should be considered include diet, including watching for the use of complex versus simple carbohydrates, moderating salt, fat, sugar, and caffeine intake, especially during the few days or several days up to a week before the onset of the menses. Smoking cessation or reduction, exercise, sleep, which could include sleep restriction if somebody, especially for somebody who is presenting with hypersomnia, decreased alcohol consumption, relaxation, cognitive therapy, light therapy, especially with those who have significant mood symptoms associated with fall, winter light cycles, and biofeedback. Over-the-counter supplements that could be useful. I know you guys have an entire class on over-the-counter and nutritional supplements, but some recommendations specifically for a PMDD include the ones that are listed there for you. Vitamins B6, E, and calcium, tryptophan, up to 6 grams daily, magnesium, up to 500 milligrams daily, and over-the-counter NSAIDs such as naproxen or ibuprofen for some of the physical discomfort. I would add, and I don't have it listed there, but just like tryptophan, the use of SAMe has been, I have found clinically useful for women who reported both mood lability associated with premenstrual syndrome or premenstrual symptoms, as well as some of the physical discomfort. So I would add that as well. And that would be, let me add it actually as we're talking about it, anywhere from 100 to 400 milligrams daily. Could be used only in the PMDD, not specifically for PMDD. It's not necessarily significant for premenstrual dysphoric syndrome, but certainly could be beneficial for PMS. And ineffective for some women. And it could be used throughout the month or just 2 weeks before the cycle or before menstruation. As far as pharmacological treatments, the serotonin specific reuptake inhibitors would be the drug of choice for treatment of PMDD, as I mentioned, because of the association of serotonin and tryptophan depletion with the etiology of PMDD. Fluoxetine, sertraline, and paroxetine have been studied in randomized, placebo-controlled, and open-label trials. They all seem to be effective with regards to symptom relief, which is statistically significant in physical symptoms within the first cycle, decreased irritability within the first 3 to 4 days. And multiple studies support efficacy of intermittent dosing. That's what I was talking about with regards to SAMe. And that intermittent dosing would be 2 weeks on, 2 weeks off. Again, this is based on a 28-day cycle. And I want to emphasize that not all women have similar cycle length. So you want to make your prescription specific to your individual client. So in this case specifically, PRN dosing seems appropriate, and especially if you want to minimize side effects associated with these medications. Women who don't otherwise need to take serotonin specific drugs or SSRIs could benefit from taking 2 weeks off to minimize, some of the sexual side effects, potential weight gain from Paxil, and other issues. Dosing is relatively low compared to what standard doses for the treatment of depression with Prozac. Average dose being about 20 milligrams per day. Again, it could be full cycle or intermittent dosing, depending on what's appropriate for the patient. The most common side effect with Prozac is delayed orgasm in the long term, and this is an FDA-approved indication for this medication. So if you look it up on Hippocrates or other drug information, like the drug insert, you should be able to see that as an FDA-approved dose. For sertraline, we see once again that minimum doses or low doses, again relative with doses that are standard doses that are used for depression, may be beneficial. Also can have full cycle or luteal phase only dosing. And it's also, you can see some of the benefits listed there. You could have transient GI and sexual side effects and with Zoloft, and it is also FDA approved for this use. Paroxetine, 10 to 30 milligrams. Full cycle is what the studies have shown. You might see transient GI and sexual side effects, and it's also FDA approved. Again, since I am talking, one thing that I forgot to mention, by the way, at the beginning of the site is that I don't have any financial conflicts to report. I don't have any financial ties or any relationship with the pharmaceutical companies or agents that I talk about. So I can freely say that I tend to dislike Paxil quite a bit. And though I see its use may be appropriate in some cases, and you will see later on why I say this, its use with both women and men of reproductive age is problematic, and for that reason, I wouldn't necessarily consider it as a drug of choice for PMDD. For citalopram and escitalopram, you would expect similar results. You could use in the full cycle or also PRN dosing, meaning luteal phase only. And in this drug specifically, the findings actually say that the luteal phase use may be superior to continuous treatment, again, specifically for PMDD, as opposed to the exacerbation of depression or anxiety, and it's not FDA approved. However, again, mechanism of action is similar to other SSRIs, so education with regards to the patient may be useful. Not FDA approved, but it may show benefit, and I don't have them in a separate slide. So just so you should know, some of the newer drugs like Viibryd, Remeron, Trintellix, and Fetsima, although Fetsima is more SNRI-like. So in practical use, I don't know. To be honest with you, I have a somewhat limited formulary in that the government doesn't tend to approve drugs that are just out of just off, just off the shelves, essentially, newly marketed until there's enough evidence that they have a mechanism of action or effects that are a significant improvement over other drugs that are that are in generic form already and cheaper in cost. And so I haven't had the opportunity to use Fitzima. But I would, again, just based on the mechanism of action, even though they're not FDA approved, I would expect that Vibrad, Remeron, and Trintellix may have beneficial effects as well. In the antidepressants, it's going to be a little bit harder to follow this slide, so I'll try to do a little bit at a time. This is a good guide. This slide is a good guide that you might want to keep handy. Again, if you're providing consultation or ultimately being able to prescribe to women who have PMDD, the differential dosing for fluoxetine and other SSRIs, and whether you'd want to use in continues or luteal face only. And again, actually, I would add here, based on what I told you in the previous slide, that luteal may be preferred for citalopram and escitalopram. At the time that this study was published, escitalopram had only preliminary evidence, but I think there's enough support that I would consider it, if all things being equal, I'd consider it a good agent to use as a first-line treatment. As far as the SNRIs, venlafaxine has demonstrated efficacy. Again, you would suspect that Fitzima and desvenlafaxine and potentially duloxetine would have similar effects. Continuous dosing is what has been studied for this SNRIs. As you are aware, venlafaxine and other SNRIs have very significant discontinuation effects, and that's what makes PRN dosing more difficult. So once again, I think ideally the first drug of choice would still be the SSRIs, unless the person is unable to tolerate them, or they're already on an SNRI for another psychiatric condition. As far as the anxiolytics, there's evidence, some conflicting, for use of things like alprazolam or Xanax or buspirone in the luteal phase, specifically because those are pretty acute effects, or present with very acute effects. But there's problems associated with their use, as you know, especially the alprazolam or any other benzodiazepines that may impact or that may affect functioning, or may cause sedation, or difficulties with regards to managing day-to-day activities. So not as recommended as the SSRIs. Okay. But as I mentioned, they may be reasonable options for anxiety and irritability. Of course, you want to discontinue after the onset of menses. This would help to decrease some of the risk associated with tolerance and abuse, specifically for the benzodiazepines, not so much for Buspar. I haven't really ever seen anybody abuse Buspar, but I suppose it's possible. Dextroamphetamine may be helpful to improve lethargy, poor concentration, and increased appetite. These are all, of course, non-FDA approved treatments or options. And again, you'd want to minimize the use due to potential for tolerance and potential for abuse. Oral contraceptives have been recommended by the American College of Obstetrics and Gynecology, sorry about that, for irregular cycles, acne, and of course contraception, but they're really not recommended for the treatment of PMS or PMDD. So if you got patients that are coming to you that have been prescribed the oral birth control pill, or any other contraceptives, hormonal contraceptives, that is for the treatment of PMDD, the evidence is just not there. And so you might want to have a conversation with them about potentially switching to, unless they need to be on contraceptives, potentially using an SSRI instead. Joyce says, I would be careful with any stimulant, with anyone who has any kind of eating issues, thinking of our client from earlier. Absolutely. Yeah, you definitely want to take that into account. And again, I want to emphasize that these are not FDA approved uses of, medications like dextroamphetamine or even the benzodiazepine. So you want to be very cautious about who and how to prescribe. And again, I would probably not use these medications unless an SSRI was contraindicated for some reason or was ineffective. Okay, thank you all. And we're going to move to another poll question. So here it is, ready to go. All right. We will just give the last remaining chance to anybody who wants to input their answer, and otherwise end the poll. All right, so question is, given the most commonly proposed etiology of premenstrual disorders, one would anticipate a better response from the following psychotropic. And the answer, which 83% of you who responded chose, the correct answer is serotonin-specific reuptake inhibitors, or SSRIs, rather than norepinephrine dopamine reuptake inhibitors. That is the correct answer. It is possible that some of the other answers are good enough, but again, based on the etiology, the question asked based on the proposed etiology of PMD that we described on slide 92, it is the decreased levels of serotonin or serotonin depletion, as well as tryptophan depletion, that is proposed to be the etiology for premenstrual disorders. So thank you for participating. Good job. And we'll go ahead and move on to the next topic. Okay. And the next topic is birth control. So good segue based on my comment before about the fact that they're really not great treatments for PMD or PMDS, PMS or PMDD. Birth control and other hormonal agents. We're not going to spend a great deal of time talking about this. More so than anything else, I want you to be aware of how these agents work and how you may encounter patients who have complications, issues, associated with the use of birth control. And more importantly, what I mentioned before is the interaction of some of the drugs that we prescribe with hormonal birth control agents, but it's not really necessary for you guys to memorize all the things that are listed on this slides. So hormonal birth controls come in many forms. As you can see, we have several that are in the market include implants like that are mostly progestin and are deemed to be 99% effective. Injections, especially in depot form or extended release form, that are 94 to 99% effective. Oral, usually a combination of progestin, combination of estradiol or estrogen or progestin only, 91 to 99% effective. Patch form, also a combination, and you can see the effectiveness rates are very similar. And the contraceptive ring, which is also a combination. Their mechanism of action are are multifaceted. Once again, there's several ways in which oral contraceptive pills specifically, but I think we can generalize this to other forms of hormonal contraception, prevent pregnancy. They do so by by inhibiting ovulation. That is the first mechanism. So if you don't ovulate, if an egg is not released, then there is no conception. One of the ways that happens is in the early follicular phase. FSH concentrations and mid-cycle peaks of FSH and LH are not observed, so they prevent the surges of FSH and LH that are important to ovulation. And of course that results in decreased ovarian function. They also act directly on the cervix to increase its thickness and decrease the quantity of cervical mucus, and therefore inhibiting sperm penetration. So they make the conception environment less habitable, less welcoming, I suppose, to sperm. And also inhibit the development of the endometrium, that uterine lining that is essential for the implantation of the ovum, the fertilized ovum, and the development of the fetus, and ultimately the maintenance of pregnancy to be able to happen. Some advantages of hormonal contraception include things like the improvement of acne, menorrhagia, and dysmenorrhea, as we talked about before. And therefore, these medications are sometimes used in women who are not sexually active. So don't assume that just because somebody is using birth control that they are necessarily using it for as a contraceptive agent. They can help regulate the cycle in women who are not normally ovulating or do not ovulate in every cycle, and therefore can, in some cases, increase fertility. They are associated with a 50% reduction in ovarian cancer with 5-year continuous use, and 80% reduction with over 10 years of use. They reduce the risk of endometrial cancer, and again, you could see the rest of them for yourself. Some decreased risk of pelvic inflammatory disease, fibrocystic breast disease, and iron deficiency anemias. They do have some disadvantages, and it's really important for you to be aware of this. Spotting, especially in the first few months. Again, my particular practice is full of young women. You know, most of my typical patient is a young man or woman between the ages of 19 to 24. And so I do see a lot of this things happening potentially for the first time if the woman has not been on hormonal birth control before. They may decrease sexual interest or libido. They may exacerbate mood symptoms or present with mood lability or mood swings in women who may be predisposed for mood disorders. They do require daily administration, at least the pill does. You know, you could see for yourself that other agents may require less than daily administration and therefore may be more helpful when it comes to adherence. They don't provide any protection against STDs. We see some potential for weight gain. And one of the issues that may be associated with long-term use is the potential for post-contraception amenorrhea. Again, the cessation of menses. So women could be on the pill for a significant period of time, discontinue as a means to plan for pregnancy, and it may take several months, and in some cases, some medical intervention before they actually start menstruating again. And I would want to clarify that usually the oral contraceptive pill does lead to monthly menstruation, but some other forms of hormonal contraception, such as Depo and injections, may actually prevent menstruation. It depends on how it's being used. Risk associated with hormonal birth control include idiopathic venous thrombosis. The risk is 2 to 6 times greater, and may be dose related and decreases within 1 month of discontinuation. Hypertension is a risk, cervical cancer in some users, especially with prolonged use. Cerebrovascular accidents, or the risk may be heightened, gallstones, hepatic tumors, and post-pill amenorrhea, which I've already mentioned before. And this could potentially be permanent in some women. Okay, there are some contraindications. I won't go through all of those in the interest of time. I just want to make sure that you guys are aware of them. Obviously, a suspected or known pregnancy is a contraindication for the use of birth control. So a woman should have a blood pregnancy test, not just a urine pregnancy test, but a blood pregnancy test before starting contraception. Smoking and age greater than 35 years is highlighted on the slide, as well as obesity. Those are create serious contraindications, especially for the development of coronary artery disease or venous thrombosis and other complications from use of these agents. And then again, want to make sure that you understand that medications that interfere with its effectiveness, such as topiramate and lamotrigine and some of the other mood stabilizers, may create a contraindication for the use of this drugs. So once again, you got a young woman in your practice who has potentially a history of migraine medications and or mood instability, and maybe taken topiramate. You want to make sure that they are counseled appropriately as to the use of oral birth control as the only means of contraception, because they might actually have a pregnancy. Okay, there are other hormonal therapeutic agents that you should be aware of. Agents that are used for treatment of or management of symptoms of menopause, osteoporosis, ovarian failure, dysfunctional uterine bleeding, and luteal phase dysfunction. And so, you know, once again, just FYI, not anything that you have to memorize. Ovulation induction agents that are hormonal in nature and used for the treatment of infertility, or the condition known as anovulation, meaning a lack of development or release of the ovum or the ova. Agents such as Clomid or clomiphene, commonly used in infertility treatments. Cancer chemotherapy agents tend to be hormonal. Also, there are some examples there. And obviously, women don't have prostate cancer, but in the treatment of prostate cancer, estrogen is commonly used. Endometriosis, treatment of endometriosis often involves agents such as danazol and GnRH, gonadotropin releasing hormone itself, or analogs as well. Okay. All right. We're going to move on to talk about pregnancy and postpartum. And this is the longest section. So I know we're not going to finish today. We're going to cover as much as possible and talk about postpartum and lactation tomorrow for sure. This is as I said, this is the largest area of new knowledge potentially when it comes to this class versus other classes that you have had. And there's a lot of facts to go over, so I just ask you to be mindful and be patient and, ask any questions that you may have as we go forward. Um, So important things to consider is that with pregnancy, you might have a new onset of mental illness, especially in situations where you may have an unplanned pregnancy, or you may have a woman who potentially is in a less than ideal situation, environmental situations, financial, relationship, work related, in terms of supporting the pregnancy. You may also see exacerbation of psychiatric symptoms, especially depression and anxiety. You may see the issues such as inadvertent conception during treatment with psychotropic medications. And I will tell you, as a prescribing psychologist, the one phone call that scares you the most, especially as you're starting out, is the first time that you're going to be called by a patient who says, I just found out that I'm pregnant. And you've been treating them with any psychotropic medication, no matter what it is. And your first reaction is, oh my gosh, is this going to be the one? Pregnancy brings a lot of, issues and problems, and you'll have to deal with them. I don't know what else to say other than the fact that it's going to happen. If you prescribe, you are going to have patients who inadvertently conceive while they're being treated with psychotropic medications, or potentially even willingly conceive while they're under treatment with psychotropic medications. And you're going to have to handle those cases. And hopefully the information that I provide to you today and tomorrow is going to help you to make informed decisions and help the patient make informed decisions as to how to manage those issues. Other issues to consider are pre-pregnancy counseling with women who have a history of mental illness and maybe taking psychotropic medications, treatment planning for women at high risk for postpartum mental illness who plan to nurse. So there are several issues associated with pregnancy that obviously we need to talk about. And before we do, we actually have another poll coming up. So let's go ahead and post that. All right, here we go. All right, we will offer you the last opportunity to answer the question if you haven't done so. And with that, I'm going to go ahead and close the poll and publish the results. So here we are. This is a question. Thank you to Nina for responding in the chat. Question regarding whether or not you have the right or the responsibility, perhaps, to contact the partner of a pregnant woman due to the potential consequences of pharmacotherapy during pregnancy. And the correct answer, which 95% of you chose, at least according to the poll, is false. Obviously, you would require the woman's informed consent to be able to contact the partner to discuss the potential consequences of pharmacotherapy. Now, I will say that I highly recommend that you obtain the woman's consent, or that you talk to the woman and their partner together when you talk about the potential consequences of pharmacotherapy during pregnancy and the potential consequences of no treatment during therapy. But that doesn't necessarily mean that you could if the patient declines. So again, just important to consider that you still need the woman's consent in order to be able to have that conversation. All right. So with that, let me see. Oh, sorry, I'm moving the wrong part of the. Thank you. Okay. I'm going to close that and continue. So in the interest of time, because I'm already looking ahead, I will give you information about this case example at the end of today's lecture for you to do pretty much the same thing that you did with the previous case example. Consider some questions as some assessments that you might want to do, or some things that you might want to consider, and also different ways that you can manage the care of the patient. So we will come back to slide what is this, 119. But right now, we are going to go on to talk about pre-pregnancy counseling. So the reality is that up to 50% of all pregnancies in the US are unplanned. And those numbers really haven't changed that much with higher levels of education, even with higher SES, although SES is related in significantly to planned versus unplanned pregnancies. Over time, we really haven't been able to change the needle, move the needle too much when it comes to unplanned pregnancies. The statistics say in 2011, and I couldn't find anything more recent, unfortunately, that about 40% of those unplanned pregnancies do end up in abortion. 48% of women under 44 have dealt with an unplanned pregnancy in their lives. And 80% or close to 80% of teenage pregnancies are unplanned, with most unplanned pregnancies occurring to women below the age of 24. Let's see. There have been some declines in teenage pregnancy over the years, so I don't want to sound the doom alarm just yet. So there have been some declines in teen pregnancies, especially teen unplanned pregnancies over the years. But again, as an overall total, the number of unplanned pregnancies hasn't really changed all that much. Higher rates, maybe this is, yep, actually it's in the next slide. So unintended pregnancy rates per 1,000 women were highest among women who were between the ages of 18 to 24, as I mentioned before, had low income, so low SES is associated with higher levels of unplanned pregnancies, had not completed high school, were non-Hispanic, Black, or African American, and were cohabitating but had never married. So, some areas to consider with regards to risk of unplanned pregnancy as well. Again, in the interest of time, we're going to skip the next case example. We might be able to go over it tomorrow because I think that's important to your learning. With regards to medication use, in the US, 9 out of 10 women take at least one medication in pregnancy, and 30% of women reported taking more than 4. So, you know, this ideal or this thought that we may have that the best answer is to avoid any kind of medication use during pregnancy is clearly out of step with the reality. On average, women take more than 3 medications or about 3 medications, which is an increase from 1.7 in the last 25 years. So increasingly, women are taking medications during pregnancy, and some are appropriate. In some cases, very appropriately and also very safely. Common symptoms that are treated during pregnancy or treated with medications during pregnancy are nausea, vomiting, GI upset, which are common symptoms, at least for some women, of the initial stages of pregnancy, edema, and the common cold, as well as other minor aches and pains that are maybe associated with just life in general or the condition itself. 40% of pregnant women, or roughly 40%, have taken medications during the first trimester. And why this is important is going to become clear when we talk about the critical stages of development. But again, you know, it's a we're pretty far from the ideal of taking no substances during pregnancy. This comes out of, I wish I would have, I didn't copy the link, I apologize for that, but this is part of an educational campaign geared toward avoiding some medications during pregnancy, educating women about the use and misuse of medications during pregnancy. Some risk associated with medication use are birth defects, pregnancy loss, prematurity, infant death, developmental disabilities, and other unknown outcomes. That's not necessarily true for all medications, and especially all psychotropic medications, but it's important to be aware of those. All right. The next topic is that we're going to talk about is teratogenesis, or malformations and negative impacts on the baby or the fetus as a result of medication use. So rather than start and pause, I think let's go ahead and take our last break of the day. It's 4 minutes after the hour now, so take a 10-minute break now, and we'll come back and cover the rest of this topic in 10 minutes. Okay. We are on slide 125, and as I said before, we're going to be talking about teratogenesis. So, important concept.
Sorry to interrupt. Is it okay that I just have an attendance right before we start?
Yes, let's go ahead and do that. Thank you.
Few more seconds before I close the attendance.
Mhm. All right. Okay, we'll keep going. Teratogenesis is a pretty heady topic, but don't be discouraged. It will make sense. I think it will hopefully reinforce some material that you've covered both in some of your psychopharmacology program classes and also your undergraduate and graduate courses. So essentially, for definition, teratogen is a substance which, when present during a critical period of development, which we'll see later on, produces a congenital defect. Critical periods of development is a concept that you probably learned in your human sexuality, human development classes in undergrad, and you might remember some or not at all. But again, it's going to become clear as we talk about it. Teratogenesis is an important concept, and again, you know, it's really something to be aware of. Birth defects are known to occur in about 3 to 5% of all newborns. In most cases, the cause is unknown. It is also the leading cause of infant mortality in the United States, accounting for more than 20% of all infant deaths. 7 to 10% of all children will require extensive medical care to diagnose or treat a birth defect. And approximately 65% have no known or identifiable cause, is what I said before. So 2/3 of the time that a child is born with a birth defect, even with extensive medical histories and preventative care that might have been available to the mom, we still are not able to determine which agent could have caused those birth defects. Agent or substance or potentially environmental exposures. Fewer than 10% medications have enough information for anybody to be able to determine their teratogenic risk. And so you could see how this is quite complicated. There's this concept called the Wilson's principle. And Wilson is a geneticist that put forward these principles back in 1959. They guide the study and understanding of teratogenic agents and their effects on developing organisms, and they haven't really changed since 1959. They seem to be pretty accurate and have withstood the test of time. Not all the principles are included here, but the most important principles, I think are mentioned because we need to know them. The first one talks about susceptibility varying depending on the developmental stage at the time of exposure to an adverse influence. So this goes back to the concept of critical periods of susceptibility or critical periods of development. And again, all will become much more clearer once I show you a picture of what this means. I don't know about you guys, but I'm kind of pretty much a visual learner. So listening to a concept and learning the concept may be facilitated by a picture representation. So that's what I'm trying to do. The second one of Wilson's principles states that teratogenic agents act in specific ways on developing cells and tissues to initiate sequences of abnormal development events. Translation: they don't act randomly. Teratogenic effects are not random. Each drug has specific, each known to be a teratogen has specific impacts on the developing organism. Again, it's not random. Number 3, there are 4 manifestations of deviant or development. Those are death, malformation, growth retardation, and functional defect. So death, of course, would represent, in the case of the developing fetus, would be manifested by miscarriage or spontaneous abortion. Malformation would be a birth defect. Growth retardation is exactly what it means, and the functional defect may be something like pulmonary hypertension, which is something that I'm going to show you, or the Epstein's anomaly, which is something that I'm going to show you later on. Number 4, speak to several factors that affect the ability of the teratogen to contact the developing conceptus. And that is the nature of the agent itself, the route and degree of maternal exposure, so how much and how, rate of placental transfer and systemic absorption, and composition of the maternal and embryonic fetal genotype. So complicated sentence, but essentially it means that the ability of the teratogen to affect the fetus depends on many factors, including the nature of the agent, as well as the route and degree of exposure. Those are the big takeaways from number 4. As far as number 5, manifestations of this deviant development increase in frequency and degree as dosage increase. So there are dosage related effects from the level of what is called NOAEL, or no observable adverse effect level, to a dose producing 100% lethality, which is termed in genetic studies as LD100. LD100, 100% lethality. So in rat studies, the dose at which most organisms, or 100% of the organisms, would have died. So this is a picture that I wanted you to see and understand with regards to critical stages of development. This as it relates to, of course, fetal development. So if you recall, again, from your human sexuality or human development classes, the period of conception or a pregnancy essentially starts at the moment of conception. In terms of the 38 to 40 weeks that are conceptualized to be a period of pregnancy start at the moment of conception. And of course, you know that the woman doesn't even know she's pregnant until potentially 3, 4, maybe even 5 weeks after conception. 2 weeks would be the approximate time in which the woman would have missed her first period. Again, approximate because it depends on women and the regularity of their periods. So 2 weeks would be the earliest possible time in which a woman might have missed a period and determine that she could potentially be pregnant. More typically, we see somewhere between 3 and 6 weeks as the first time that the woman starts noticing symptoms, changes in her body, and other signs that she might be pregnant, and may actually have a home pregnancy or a blood pregnancy test. So you could see in the picture, first period after conception, we have dividing cells and implantation. During the 3rd week, I want you to pay specific attention to the colors that are highlighted in the graph as you see the number of weeks at the top, 3 through 38, and the stages of development. The purple, light purple, representing highly sensitive periods, and the light green, for example, here, less sensitive periods. So, weeks 3 through 32 to 16, to give you an example, are highly sensitive periods for the development of neural tube defects and mental retardation, and weeks 16 to 38, less so. And, obviously it's specific to each of the individual organs. So weeks 3, roughly 3.5 through 6.5 are highly sensitive for the developments of truncus, arterius, atrial septal defects, and ventricular septal defects, otherwise known as problems of the heart. Or heart malformations. And then less sensitive periods are between 6.5 weeks and 8 weeks, et cetera, et cetera. I'm not going to go through every single one of them, but I do want, again, this is really the best way that I can present to you what we mean by critical stages of development or critical periods of development. So obviously, if a teratogenic agent is going to have an effect on the heart, the critical period with regards to exposure to that agent would be between 3.5 weeks and 6.5 weeks. If it might have an effect on things like muscular skeletal formation or even formation of the genitalia, it's going to be much more significant between, at the bottom, you could see that 7.5 weeks and 9 weeks. And essentially all, if not, yeah, pretty much all of the teratogenic impacts are going to be more significant in the first trimester. First trimester up to 13 weeks of pregnancy is where, once again, most of these critical periods tend to be highly sensitive as opposed to less sensitive periods. So hopefully that makes sense to you as you see it that way. You are not going to be required to memorize which teratogenic effects are, are more observable week 6 or 8 or 16 or 32 or anything like that. I just want you to be aware so you have a better understanding when we discuss the different psychotropic medications as to why they may be more of a problem in the first trimester and how they may be a problem in the third trimester compared to those to the first or second trimester based on their mechanism of action. Okay. There are some known teratogens that most everybody is familiar with. The first one is alcohol. Alcohol, as you probably know, is responsible for the development of fetal alcohol syndrome, or FAS, and it's known cause of intellectual disability, the leading cause of intellectual disability in the Western world. Its prevalence is somewhere between 0.5 and 2 for every 1,000 live births in the United States, according to the Centers for Disease Control. And children with FAS present with very significant characteristics that are observable in their facial characteristics, and also cognitive and behavioral characteristics that some of you may have some experience with. I don't know if anybody in the audience is a child and adolescent psychologist. I have not been, and probably never will. But my first job right after my undergraduate degree was with Child and Family Services, or Child Protective Services, and at the time, and this is of course, all anecdotal information at the time, the biggest contributor to and I'm aging myself, of course, contributed to children being in the foster care system was alcohol abuse versus, prescription drug abuse as it is now in the parents. And I would say probably 60 to 70% of my caseload was children who had fetal alcohol syndrome, at least to some degree. Other known teratogens that you should be aware of are things like, we talked about danazole, which is used for the treatment of endometriosis, other, hormonal agents, but things like lithium, anticonvulsants, cocaine, and I highlighted isotretinoin or Accutane because, you should know that it has a significant black box warning and contraindication for potential or known teratogen effects. And then you see some of the other ones listed there. We have some suspected teratogens, meaning we have some evidence that they may be the cause or may have teratogenic effects, but the data is either not sufficient or maybe contradictory. And again, this is complicated by the fact that most women will take up to 3 or 4 different medications during pregnancy. And so, really pinning down the teratogenic agent may be difficult. And those include, as you can see highlighted there, benzodiazepines and the tricyclic medications, though they're not all the same. Drugs that have non-teratogenic adverse effects. So non-teratogenic would be things that could potentially affect the development of the development of the fetus without necessarily creating a malformation. So things like barbiturates, beta blockers, benzodiazepines, caffeine, and nicotine, and narcotics may be associated with things like growth retardation, may be associated with spontaneous miscarriage, hyperactivity, or even flaccidity or withdrawal effects on the neonate or the baby, but not necessarily with birth defects. And their effects are varied. So just want to make sure you keep that in mind. We have a couple more poll questions here. So let's go ahead and we'll do number 1 and then number 2, meaning number 7 and number 8, and then share the results together for those. All right, let's go ahead and move to the next question. All right, I'll just give you guys a couple more seconds to finish up any answers you may have, and close out this poll. And let's go ahead and share the results. And I don't know, Aiden, I'm going to need your help with posting the results of the previous question. But for this last question, the number of women who take medications during pregnancy is estimated to be, that would be about 80%. But let's double check because I want to make sure that I give you the right information. If you look at slide number, what is this, 123. What we said there, let's move this out of the way. Is that we had about 30% of women who take, who have taken at least, let's see, what do we have? 40% of women have taken medications during the first trimester. 9 out of 10 women take at least one medication, and 30% reported taking more than 4. So none of the answers were actually exact to what was briefed, and that means that I probably need to modify the question a little bit. But the most accurate answer based on this is that 80%, since 9 out of 10 have taken a medication during pregnancy. Most accurate answer would be D, which is 80%. So sorry about that. We'll definitely modify that question in the future. And Aiden, can you help me with sharing the results of the last poll, number 7? All right, so that question is: the rate of unplanned pregnancies in the United States is significantly lower than in most developed countries. Therefore, the risk of psychotropic use during pregnancy could reasonably be reduced by appropriate pre-pregnancy counseling. We had an complete even split with 10% or 50% saying true to 50% saying false, and the real answer is false. The rate of unplanned pregnancies in the U.S. is not lower, but is also not higher than in most of the other developed countries. It's pretty much the same. And I did not make that clear in my slides before, so it's a little bit of a trick question. I apologize for that, but I wanted you to wanted to find a way to emphasize the information that we shared before. Okay. So we are going back to our slides. It's a little bit tricky here, sorry. Okay, that made work. All right, so moving on, we talked about physiological changes that happen during pregnancy that may affect how drugs are metabolized. We talked about this already, so this is just reinforcement: delayed gastric emptying, delayed decreased GI motility, may enhance the absorption of the drugs. And we talked briefly about how those effects all tend to translate into a slower, higher absorption or higher availability of the drug, and decreased or slower elimination. So this is just additional emphasis on the same concept. I want to talk a little bit, talk next about the category, how drugs are and were categorized depending on risk levels for pregnancy use. And some of you may be familiar with this category system, A through D, and then X, because it's not necessarily A through X, that we used prior to 2015, and that'll be in a later slide, so I may be off a little bit. With category A, essentially, you could read this for yourself, being the safest drugs, or the drugs that had the most amount of information indicating safe use during pregnancy. And category X essentially being the complete opposite, meaning drugs that were completely and uniformly contraindicated for human use during pregnancy based on studies or knowledge of risk associated with their use. So obviously things like known teratogens, like alcohol, would be categorized as an X drug. This is no longer the labeling system in use. We now have a system, and I described it here as new labeling, but it's really only new as of 2014 and implemented for use in 2015. So effective June 30, 2015, as you can see. The previous, which is now described in this graph, described as the current labeling, was different for pregnancy versus labor and delivery versus nursing mothers. And we now have a new category that in more specific information where we also address females and males of reproductive potential. So pregnancy is now defined as including labor and delivery, lactation, also including its use in nursing mothers, and then the new category being females and males of reproductive potential. So when we talk about the different drug types, just keep this in mind. The labeling changes went into effect in 2015, as I said. That does the problem is that the use of the new format became immediately required for drugs that were approved on or after June 30th of 2001. I'm sorry, for drugs that were approved after 2015 or submitted for approval after 2015, but drugs that were approved between 2001 and 2015 were to be phased in gradually. And most of the psychotropic medications currently in use have been phased in to the extent that they could be phased in. But as you can see, drugs that were approved and marketed prior to 2001 do not have to conform with the new labeling requirements. So things like benzodiazepines, most of the first generation antipsychotic medications, and even some of the SSRIs like Prozac, which was developed and marketed brought out to the market to marketing in 1987, don't necessarily have to comply with those rules, although for the most part they have. Over-the-counter medication labeling did not change. I just noticed a typo there. And over-the-counter drug products were not affected by this change. So obviously there's a lot of over-the-counter nutritional and other supplements that could be used by women of reproductive age or by pregnant and lactating women, and we just don't know how they may affect the women and their child. So let's talk about antidepressants. In to varying degrees, all antidepressants may be associated with neonatal persistent pulmonary hypertension, neonatal serotonin syndrome, neonatal withdrawal symptoms, low birth weight, and premature birth. And we're going to talk about the reason why this may be. But before we do that, I want to emphasize that this is an important slide. So I'm not going to ask you to memorize which agent, may be associated, which specific antidepressant may be associated with more or less risk of any of these conditions. But it is important for you to know that to some degree, all antidepressants could be associated with any of these effects. Looking through time, obviously, if we start from a historical perspective, the TCAs were the first in use in terms of antidepressant medications. And for the sake of presenting the information, I couldn't really give you information about every single TCA or every single drug in the other classes of antidepressant medication, but I'm giving you some examples. Amitriptyline was previously category C. And if you go back to the slide that shows the category C essentially said relatively safe. There's some information or not enough information, or the information that we have is based on animal studies versus human studies. Therefore, you know, consider the risk, weigh the risk versus the benefits. And again, essentially, the drug is relatively safe for its use in pregnancy. Pamela, on the other hand, was previously a category D drug, meaning it was contraindicated, not as badly as a category X, but certainly contraindicated for its use during pregnancy because there was enough evidence to show in either animal or human studies that there could be negative effects on the fetus. The new labeling, as you could see, says caution advised during pregnancy, especially in the 3rd trimester. Possible risk of teratogenicity based on conflicting human data. Possible risk of neonatal withdrawal symptoms based on limited human data. So Pamela would still be considered a contraindicated drug when it comes to pregnancy. In general, TCAs are not associated with congenital malformations, and I know we listed them as suspected teratogens in a previous slide. That is, again, there's no definitive data that says one way or the other. Certainly for Pamela, there's more evidence that it should be avoided versus not. Some earlier studies suggested an association with birth defects, primarily in the limbs. As in a limb development, so shorter legs or shorter arms. Some reports of fetal tachycardia are also present, and dosage may have to be increased in order to maintain adequate therapeutic concentrations and response, but of course need to assess the risk versus the benefits. All right. As far as neonatal effects, we could see withdrawal symptoms, just like you would expect to see serotonin withdrawal syndrome associated with SSRIs. You would expect the same to be true for TCAs, most of which have either an SNRI type of mechanism of action or potentially more of an SSRI type of mechanism of action, and therefore, some I would say SSRI-like, not necessarily SSRI, but you would expect to see withdrawal symptoms if the drug is not discontinued or it's tapered before delivery. Symptoms of this discontinuation symptom include jitteriness, lethargy, tachypnea or rapid breathing, tachycardia, cyanosis or bluish coloring, and some of the other ones that you see listed there, including anticholinergic effects like constipation and urinary retention. You had follow-up at age 7, in one study at least, reported no suggested or reported no neurobehavioral abnormalities. Second category of drugs in the antidepressant class to think about is the MAOIs. As you know, they are not very commonly used, especially this day and age, because we have a lot of other options that are appropriate. Previously, most of them were considered category C. Again, you know, weigh risk versus benefits based on either conflicting or not enough data. And that remains mostly true. Things to think about with the MAOIs is, as it's highlighted there, possible risk of vasoconstriction based on the drug's mechanism of action. And you could see similar indications for Parnate, again, based on its on the drug's mechanism of action. in general, and again, I just provided you a couple of examples, what you might expect to see, or what we would see is that previously all were classified as category C. I mentioned that already. In one small human study and in animal studies, there were some reports of teratogenic effects. But the problem with MAOIs, as it is either even with other patients of non-reproductive age, is that the dietary constraints and potential for a hypertensive crisis make it really hard to consider these medications, and especially in pregnancy, make it relative contraindications to use. Okay. As far as the, I think I'm going to go over the SSRIs briefly, and we're going to get more information on more specific information tomorrow, but I want to make sure to allow a little bit of time for to go over the details of the case example. Sertraline, fluoxetine, citalopram, and fluvoxamine were previously category C. And again, you can read for yourselves what the new labeling says, pretty much along the lines of what I said to you before. Risk of neonatal withdrawal symptoms or serotonin syndrome is possible based on human data. Risk of neonatal persistent pulmonary hypertension or autism are inconclusive. And we'll talk more about the autism risk tomorrow. Paxil, however, was previously a category D, and you can see for yourself what the new labeling says. Based on the fact that it was previously a category D, and based on its risk associated with for women and men of reproductive age, as I mentioned before, my particular inclination is not to use Paxil unless nothing else works. There's been some links to potential quote unquote teratogenic effects, including primary pulmonary hypertension, heart defects, increased risk of premature birth, a lower birth weight, especially with third trimester exposure, and rate of spontaneous abortion was higher in women who have taken SSRIs and TCAs in some studies. We talked about withdrawal effects, and there's also been reports of increased neonate seizure risk. And yet follow-up studies suggest no neurobehavioral abnormalities by age 7. Just want to give you a chance to have a look and see what pulmonary hypertension, you may have heard about it, looks like. Essentially what you see when pulmonary hypertension is present is a narrowing of the pulmonary artery and an enlargement of the right ventricle. That narrowing of the arteries then creates resistance and an increased workload for the heart, obviously. So the heart becomes enlarged. That's the reason that the right ventricle becomes enlarged. And, from pumping blood against the resistance. The symptoms may include chest pain, weakness, shortness of breath, and fatigue. The goal of treatment, of course, is to control the symptoms. The condition cannot be reversed. In some cases, it can be managed, but in very serious cases, it can develop into congestive heart failure. All right, I think I'm going to stop there. So we're in slide 147, and I'm going to go back, and unfortunately didn't get as far as I thought we might, and as I mentioned before, I kind of anticipated that, so we'll adjust course accordingly. I want to use the last few minutes to give you some information about this case example. And what I would like you to do is take a few minutes after the class. So tonight, this is your homework assignment. Take a few minutes after the class to consider the details of this case and determine whether or not, again, some considerations with regards to diagnosis, treatment, and potential complications based on this woman's pregnancy status. So this patient's name is Jessica, again, a pseudonym. Jessica is a 26-year-old with a history of bipolar disorder 1, most recent episode depressed. She experienced one severe manic episode while she was in college, about the age of 21. She stayed up for days, was irritable, and ended up almost jumping from an overpass onto train tracks with an incoming train, but was ultimately stopped by a classmate who was passing by. She has not had a manic episode in the last 3 years when she presented to treatment with me. She's now married, has been stable with no depressed or manic symptoms for 2 years. So no mania for 3 years, no depression for 2 years, and is wanting to conceive. She came to me after she was a new enrollee to the military healthcare system as a relatively newlywed. I think they've been married for about a year. And previous to that, she was seeing a primary care physician who was managing her medications, including her psychotropic medications. She comes to me on unopposed antidepressant therapy, citalopram at 40 milligrams a day, and trazodone at 50 to 100 milligrams at night for insomnia. Some psychosocial factors you should be aware of is that the husband is in a career field that leads to frequent deployments. She does not get along with husband's family and is geographically separated from her own family. Is underemployed. At the present time when I started seeing her, she had not found a job except for a part-time. She's trained as a nursing aide and ultimately found a job in a nursing home. She wants to go back to school to get her to achieve her nursing degree. And is obese. I want to say BMI was about 38% and engages in little physical activity. So once again, I don't want you to think about diagnosis. I want you to think in terms of assessment and recommendations that may be appropriate for this patient. So once again, I'm going to repeat it. I know we're running out of time and I don't want to keep you late. 26-year-old Jessica has a history of bipolar 1 disorder. Most recent episode is depressed. She has experienced one severe manic episode that ultimately resulted in a suicide attempt interrupted by a passerby, by a classmate when she was in college. She's newly married as of 1 year, about 1 year prior to start of treatment with this, with myself. Stable without manic symptoms for 3 years and without depressive symptoms for 2 years, and is looking to conceive. She's never been pregnant before, by the way, and hasn't experienced any miscarriages. She's currently on unopposed antidepressant, meaning she's only taking antidepressant medication with no mood stabilizer on board. Citalopram 40 milligrams and trazodone 50 to 100 milligrams at night for insomnia. Some psychosocial factors that are important to consider is her husband's frequent deployments, the fact that she does not get along with her husband's family, who lives in the local area, whereas her family is geographically separated. She's underemployed, currently working as a nursing aide on a part-time basis in the nursing home, and wants to go back to school and obtain her nursing degree. She's obese, about 37% body mass index, and engages in little physical activity. And that's all I'm going to say for tonight. Aiden, let me look a little bit ahead to see if there was anything that I wanted you to post. But I know that there are some, sorry about that. This is where we left off. There are some intra-session questions that are going to be posted on Moodle. Aiden, is there anything you want to close with?
Nothing on the, I already have created the between weeks assignments, especially some of the people asked for having that available as soon as possible. And I already have also, based on the intra-session, intra-class day one, I created the assignment for tonight, 6 questions for people to answer.
Excellent. Okay, thank you very much. I know we covered a lot of material and a lot of it pretty quickly, so I appreciate your patience. I don't want to keep you late, so I wish you all a good night. Just like I did at lunchtime, I will stand by for 4 or 5 minutes so that if anybody has any individual questions they want to ask, you can go ahead and do so. If not, work on your case study. Come prepared to ask questions and give inputs, and I wish you all a good night. And don't forget to complete the intra-session questions tonight. Have a good night, everyone.